Welcome to Let's Talk Micro.
Hello, everyone. Welcome to another episode of Let's Talk Micro. I hope you had a great week. As always, Let's Talk Micro, it's available on Apple Podcasts, Spotify, TuneIn Radio, Google Podcasts, Stitcher, Overcast, Pandora, Amazon Music. Wherever you listen to your podcast, you can find Let's Talk Micro. I am also on Instagram as Let's Talk Micro, no apostrophe, and on Twitter as Let's Talk Micro 1. So, like I always like to say, go ahead and follow, leave feedback, any podcast topic suggestions. They're always appreciated and welcome. I leave pictures of organisms. I give updates as to when new episodes are coming out. So go ahead and follow. And if you haven't checked out the previous episode, go ahead and do so. It was an interview episode. Great information. Dr. Charlene Kaler was on. She is the Deputy Director for the Marshall Center for Infectious Diseases Research and Training at the University of Western Australia in Perth. So she came in to the podcast, and discussed an article that she published about Neisseria species and their complicated relationship with human health. So it's some good information, here. She talks about this species, that we call them in the lab, the non-pathogenic Neisseria. So she discusses some more information about them. Typically, we see them as non-pathogenic, so we might need to start looking at them more, in a more significant way. She even talks about a DNA-dependent mechanism of Neisseria species that can actually kill Neisseria gonorrhea. So it is some good information. If you haven't checked it out, go ahead and do so. It is episode 41 with Dr. Charlene Kaler. And today's episode is another interview episode. Like I mentioned before, there's a series of interview episodes that are coming out. I had the good fortune of I reached out to many authors of different articles and they all said yes. So with the availability and everything, all these episodes are coming out around the same time. So it is some really good information. So I hope you like them and listen to them and provide feedback. So today's episode is about, we are actually talking virology. This is about HIV, the human immunodeficiency virus, which, as you know, it's a virus that attacks the body's immune system, and it can progress to AIDS, which is the acquired immunodeficiency syndrome. There is a lot of information about HIV out there. I mean, the whole world is aware about HIV and how significant it is. In the lab, we take universal precautions not for HIV only, but for other viruses as well, but we treat all the samples as potentially infectious. Today's episode is about an article that, in my opinion, it should have had more hype. You might have seen it on social media, maybe on the news. I mean, to me, it was pointed because a coworker asked me if I had read it, and I went ahead and checked it out, and then I reached out to one of the authors, and she graciously agreed and said yes. So I'm very happy about that. So the article was titled "Patient Possibly Cured of HIV Infection by Special Stem Cell Transplant." This was published on February 18th of this year at the Weill Cornell Medicine website from the Weill Medical College at Cornell University in New York. So in this episode, I had Dr. Jingmei Hsu. She's a stem cell specialist at the Weill Medical College, and she's one of the authors of this article. This article discusses that there was a patient that had acute myeloid leukemia, or AML, and this patient also had HIV. Just to make it, just to briefly summarize the article. So this patient received a stem cell transplant, from cord blood. And as of right now, 15 months after the treatment, the patient not only appears to be free from the AML, but also free from the HIV. So this is some good information. I mean, especially those of you that work in the lab, we run the sample. We learn in school about the leukemias. I mean, when we see the abnormal cells in the differential, we refer it to pathology, and then that's it. So we don't really think more about that. So in here, she discusses, the treatment options for leukemia patients, and something very interesting, that maybe at some point in time I had read, but some of us might not be aware about. There's a CCR5 gene that in patients, in individuals that do not have this gene, the virus cannot attach to your cells. So this was something, this is something very interesting. So this patient received, a stem cell transplant from cord blood that had, that it didn't have this gene. And when, with this therapy, as of right now, like I mentioned, the patient appears to be free of the leukemia and HIV. So this is something very interesting. I mean, there's only like two other documented cases about this kind of treatment, being successful. But however, this is the first one where the transplant was with cord blood cells. So this is definitely very great information. I hope you enjoy it, and definitely very thankful that Dr. Hsu came to the podcast and talked about this. So let's go ahead and listen to the interview. So on today's episode, we are talking virology, specifically about the human immunodeficiency virus, or HIV. There was this article that was published on the Weill Cornell Medicine website titled Patient Possibly Cured of HIV Infection by Special Stem Cell Transplant. So with me today, I have Dr. Jingmei Hsu from the Weill Medical College at Cornell University in New York. Dr. Hsu, welcome to Let's Talk Micro.
Yeah, thank you for having me.
You're welcome. So can we start with a quick introduction and what kind of work do you do at the Medical College at New York?
Sure. So I am a stem cell transplant physician at Weill Cornell Medicine, New York Presbyterian Hospital. So what I do day to day is really perform stem cell transplant, both autologous stem cell transplant and allogeneic stem cell transplant for patients with hematological malignancies such as leukemia, myeloma, and lymphoma. And we recently also offer a different type of cellular therapy called CAR T-cell therapy, specifically for right now approved for lymphoma patient and myeloma patient as well.
Okay. Well, thank you. So let's do an overview of the article and what it was about.
So basically, we have a patient who was diagnosed with AML about 5 years ago, and she also was diagnosed with HIV about 9 years ago. So she had a high risk AML that requires stem cell transplant. So we, took her through transplant using a special type of cord blood that is HIV resistant. By doing so, we're hoping to cure both her leukemia and HIV. So she did well with stem cell transplant. By 3 months or so, her blood system and immune system are replaced by this HIV resistant baby's cord blood stem cell. And so about 3 years after she had her transplant, we were able to take her off the anti-HIV viral medication and continue to follow her. And so far, it's been 15 months coming off her antiviral medication. We're not detecting any HIV virus. So we think she possibly been cured. And her leukemia is also not detectable at 4.5 years for now.
Okay, so let's talk a little bit about leukemia, I mean, we in the lab, especially, like in hematology, we're used to seeing the cells in the microscope, right? We get the sample. Typically, initially, we run it through the instrument, then we do our differential. We see anything abnormal, we flag it to a pathologist. So once your patient has been, diagnosed with leukemia, um, how does it typically work for the treatment? I mean, do they start chemotherapy first, and maybe if the patient doesn't respond, then a stem cell transplant is performed?
Yeah. So, once the leukemia is diagnosed, we now have the technology also to prognosticate those patients into, good risk, intermediate risk, and poor risk AML patient. Now, if patient is fit, can tolerate high dose chemotherapy, that's what we typically offer patient with the chemotherapy. Those are done in the hospital, and those patients undergoing intense chemotherapy, we can monitor them. So once we're able to get rid of the leukemia, if patient with the chemotherapy, if patient has good risk, then they do not need to go on to transplant. If patient has so-called poor risk AML, then those patients definitely will need transplant. Granted, there's no other medical conditions preventing them to be able to receive transplant. For patient in the intermediate risk, so some it's I would say AML is quite a mixture of heme malignancy disease, meaning they have different type of mutations. Some are more tilting toward poorer risk. So for those patients, we also discussing, especially their younger patients can tolerate the transplant. They should probably go on to transplant. It's a little less clear for this group of patients. Nowadays, with different type of genetic mutations, there's also targeted therapy that we can offer patient as well. For example, FLT3, mutations that we can offer FLT3 inhibitors. If patient has IDH1 or IDH2 mutations, we also have targeted therapy for those patients as well. What we find is that some of the higher risk patients, post-transplant maintenance therapy would be also become an important component as well to prevent recurrence of the leukemia. I would say there's another big area of leukemia treatment is the antibody therapy also nowadays that we have.
Okay, and as I was reading the article, I see that so there was cord blood used. Is this something that's typically used in stem cell transplants?
So for stem cell transplant in general, we're thinking about three different type of potential stem cell sources, right? One big source is adult stem cell, which coming either from matched siblings or relatives, or another source is unrelated matched donors. Now, in general, we tend to trying to do adult stem cell transplant, and if we can't find suitable, adult donors, we'll think about cord blood, because cord blood is already stored in the blood bank, specific bank, and I would say patients or recipients body are less picky in terms of stringency of the matching. Although I have to qualify that because we now also have technology to be able to do adult stem cell transplant using just 50% we call haploidentical donors as well.
Okay. So something that really caught my attention, and I know most people, I mean, we're definitely as a population, we're definitely aware of HIV. I mean, we're always told, and even through as we study and we're told take precautions, even in the lab, right? We have our universal precautions where we treat everything as potentially infectious. So can you talk more about this CCR5 gene? I mean, this is something that most people might not be aware of, and what's its relationship to HIV resistance?
Right. So CCR5 is a small protein. They're on the cell surface of a lot of immune cells, including CD4 cells, which is branch of our immune system. Now, HIV use this little protein attached to this protein to help to entering our cells, to cause infection. So the reason that we pick this particular type of cord blood that's HIV resistant is that because the cord blood has a deletion in CCR5, so that the HIV particle cannot bind and then infect the cells. So in fact, if we replace patient's immune system with this CCR5 deficient cord unit, so the HIV can no longer infect the patient.
Okay, so yeah, that's definitely very interesting. So in this case, why was it, you answered about, like using cord blood. So why was cord blood that had the CCR, well, you said it's CCR5 deficient, right?
Yeah, that's correct. CCR5 mutation, it's relatively rare, right? It exists in our general population, and people who carry this mutation appear to, have a normal life. So it has about 1 or even less percent in mostly a Northern European population. So, the reason that we were using the cord blood in this case is that, cord blood units are frozen, right? So we can actually screen for this particular mutations versus living adult. It's much harder to know which one and to screen for it. I think that's the advantage of using the cord blood in this case. And there are 2 reported cases before using adult stem cell that's CCR5 mutated. There's the Berlin case, and then that's the London case. So we knew already before transplanting our patient that potentially using a similar concept, CCR5 deficient or mutated stem cells, that we potentially could help this patient for both, her leukemia and HIV.
Okay, and is this something that is typically done in HIV patients that have, leukemia, that are candidates for a transplant? Is it, because I mean, you said like there's not that many cases, so, and it's definitely hard to find, it's difficult. It's only seen in a specific patient population, basically. So is this something that's typically done in HIV patients with leukemia? Do you try to find CCR5 deficient, blood?
Yeah. Well, I think first of all, you have to be able to identify potential unit matching the patient sufficiently in order to perform this. I do know there are other unpublished cases. Some of our colleagues scattered, perhaps in U.S. or even other locations that have tried. So I think when this is, I think our case indicate that whenever patients are suitable, if you can find the unit, that's something definitely should be considered.
Yes, definitely. And I mean, and definitely in this case, it seemed, it worked very well for the patient. I mean, not only, right, there's no more leukemia, but also it seems that the patient doesn't have HIV anymore. So it definitely benefited the patient enormously. Yes. Okay, and then just as I was, reading, right? So it says the treatment was discontinued in 2020. And this article was recently published. Is this, because this is all the time that the patient was maybe monitored to see how the patient was responding, and then by then, there was sufficient information to, publish this. Is that why it was published, 2 years after the patient stopped treatment?
Well, it's about 15 months. That what you said is correct. So we were trying to be, very cautious, right? We had cases when patient is taking off their antiviral medication and then they rebound within weeks to months. So we just wanted to make sure that we follow this patient very carefully. At the same time, we're team up with laboratories at UCLA, NIH, and I think Hopkins. Several labs were helping us to really using very sensitive, cutting edge assays to see if we can find any of those viral particles.
Okay. So yes, this was definitely a fascinating article when I was reading it, and a lot of people in the lab also mention it. They know that I podcast and I like to talk about microbiology, so they suggested this is a topic. So thank you so much. I mean, this is something that we don't, as laboratorians, we don't, like I mentioned, we get the sample, we might make the initial determination, and then after that, it gets referred to a pathologist, and especially, we definitely do a lot of HIV testing in the lab. But knowing, having an understanding of, beyond that, I think is very beneficial for us. So I want to thank you for coming here and discussing this case. Is there anything else that you can, share with the audience about this?
I think that you hit the main points. I'm just saying that we're hopeful that once we have more of those cases, we can understand what is required from cellular treatment point of view to really trying to cure HIV, and hoping to also provide some other roadmap with different technologies eventually. Hoping to be able to cure more patients.
Yes, definitely. So once again, thank you for coming on to Let's Talk Micro. And thank you for the work you do.
Oh, thank you very much for having me. Nice talking with you.
My pleasure.
Okay, bye-bye.
And that, my dear audience, is the end of this episode. I hope you enjoyed listening to Dr. Hsu talk about this article. I sure enjoyed sharing it with you. As always, I hope you have a great week. Continue bringing that passion to what you do. It's so important. This is such a great job. Continue sharing that knowledge, teaching, helping others. This is so important. So as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time, bye.